Happy Friday, everyone, and welcome to the BAM Pilot Office Hours. We have today Ryan Garst and Bill Noyes to give you some updates as well as answer your questions. I would say if you have any questions, feel free to post them at any time and as soon as possible in the question tab in the navigation pane. Our updates typically from our team are fairly short, and we want to make sure we have time and get to everybody's questions at the end. So without further ado, I'm going to hand it right over to Ryan. Ryan?
Good morning, everyone. Just really quick, like Jen said, we're going to go through just some quick program updates. It's going to be really short. And then Bill will take over some reimbursement reminders because just to clarify some things for questions we still haven't coming in, and then we'll just open it up at the end. I see a couple folks have already put in some questions, so that's great. We'll get to those as soon as we're done. You can go on to the next slide, Jen. So I just wanted to give an update as of 1/3 from the data collection tools that everyone's been turning in. Very excited to say we've done over 80 doses in the program. And really that was primarily the week of Christmas, New Year's, and then that sort of first week. So, I mean, fantastic work. Again, just to give updates, over 60 provider organizations with over 160 locations in the country. And we are, for those of you that have been turning in the clinical data, we're actively compiling that reported data just for review and analysis, you know, the age ranges, how the infusions have went. But just for folks that are wondering, most of the locations I've spoken to or gotten data back from, the infusions are going very, very well. Very minimal side effect or adverse event or infusion related issues. So that's a really great number and a great thing to note. And data collection tools will be going out today for everyone for the dates of 1/11 through the 17th. And those will be due again on Monday, January 18th. And that's all I had today. So I'll turn it over to Bill really quick, and then we'll get to questions as soon as possible.
Great. Bill?
All right. Great. Thank you. Yeah, I really wanted to review some key elements of the program and how Medicare allows for billing as a reminder, and also point you to some new resources that just came out earlier this week. So you must be enrolled to bill for COVID treatments, which is for the vaccines and for the monoclonal antibodies. Home infusion pharmacies, if they are enrolled with the ABMAC as a pharmacy, they need do nothing. They can bill through that entity. Or if they are not enrolled with the ABMAC as a pharmacy, there is a fairly quick process to enroll as a mass immunizer, which will allow you to bill. There's hotlines, and at the website link at the bottom of this screen is an NHIA tool that has pretty much all of this information, as well as those hotline numbers to the ABMACs that you can call to get registered. Since the monoclonal antibody is being paid for by the government, it's free to those that get it through this program. And even outside of this program, it should not be included on the claim. It's not to be billed for when it's provided for free. What there is an allowable for the administration of the monoclonal antibodies. And this is, the rate is $309.60. The rate is all inclusive of supplies, equipment, and services. And the administration should be billed by the entity that actually administers the product. There's no patient copay or deductible. Medicare will pay the full allowable. And in addition to Medicare traditional fee-for-service beneficiaries, you are to bill the Medicare Advantage beneficiaries to the ABMAC. That's a little different than in the past. Or with any other products, you would normally bill the Medicare Advantage plan for services rendered, but in this case, you bill it to the ABMAC. Next slide. Oh, so here are links to a number of resources. These are on the NHIA tool, but if you're seeking general instruction, they've got a program instruction guide for monoclonal antibodies. And within that are links to enrollment, links to the HCPCS codes and rates. And this last link is the CMS FAQs regarding COVID-19. Now, this is something they recently updated, and they've added a section that starts on page 120 titled Drugs and Vaccines under Part B. And the information that we've relayed on these calls is consistent with this Q&A. So I would urge you to review it. In the next couple of slides, I've pulled a couple of key Q&As that coincide with a lot of the questions I've been receiving. So next slide, Jen. Or Ryan, or whoever's running the slides here. So will Medicare pay specialty pharmacies for obtaining and preparing monoclonal antibodies for use by another provider or supplier? This is a question we've received. So if a home infusion pharmacy is dispensing the product to a home health agency who is going to administer and bill for these services, or to a skilled nursing facility that is going to administer the product, there is no payment for the dispensing. The entity actually infuses the product should make the payment. Now, there is a possibility that you could have a subcontractual relationship with that entity and that they would pay you for your services to prepare and provide the supplies and deliver those to the patient or the nurse that's administering. The other thing is that you could have a subcontractual relationship with the nurse that administers the product, and in that scenario, you would bill. So you could use your own nurse, your own employed nurse, or you could subcontract that nursing. In that case, you would be the one that's actually paying for the administration of the product and could bill Medicare for the HCPCS code related to the administration. So that's a question we've received. I know it's come up on this call a couple times with another association, ASCP, and some guidance that's provided there, but this is pretty black and white. Next slide. The other question that's come up, and this really relates specifically to our program, is normally in a skilled nursing facility, consolidated billing requires that the nursing facility provide all of the services under their roof. And the question here is, does the skilled nursing facility consolidated billing, preclude outside entities from billing Part B directly for furnishing monoclonal antibody products to treat COVID-19? And the answer here is no. So they've set up an exception that allows for either the skilled nursing facility to bill for the administration as kind of an add-on payment, or for an outside entity to go in, provide the service, and bill directly for it. I think that's an important distinction. It's outside of the norm, and it's an exception they've set up to really facilitate the administration and make these products available. So those are just a couple of the highlights. There are many pages. Like I said, what I've read there is consistent with what we've relayed and what is in our tool from a billing standpoint. And that is all I had for today. So I think we move on to questions now, Jen.
Yep. All right. And the questions are coming in, so make sure you, Ryan, did you have something?
Yeah, sorry, Jen, I didn't mean to interrupt. One thing I forgot to mention, everyone, is just this week, I think actually yesterday or the day before, HHS and ASPR did announce expansion of the speed pilots to cover dialysis centers, federally qualified healthcare facilities, as well as prisons and or jails. So those locations would fall underneath the purview of our pilot. So if you were to get a request from a prison or want to work with the dialysis center or anything like along those lines, or a federally qualified healthcare facility, you can use the product that we are allocating to you through our pilot here for those facilities. So I forgot to mention that in my slides. I apologize. But I just want to make sure that everyone is aware of that, that we can now expand that to those facilities, again, federally qualified healthcare facilities, dialysis centers, as well as prisons and or jails. So that's all I wanted to mention, Jen. Sorry, I forgot to put that in the slide.
Great. Thanks. And I think it, you know, another clarification, and I think we've said this before, but it can be a little bit confusing as they expand that pilot, as you reviewed, Ryan, and we look at potentially, you know, administering the BAM product to staff. It is important to know that anybody that gets the product still needs to meet the emergency use authorization criteria. So, you know, if you have a 20-year-old that works in a skilled nursing facility and does not meet any of the criteria under the EUA, we cannot dispense the BAM. And we want to make sure that so there's really is two things. It's the pilot criteria, but there is also the clinical criteria for the medication itself. So Ryan, anything to add on that? Because we have a couple of questions about that in the chat, as well as we've had that in the past.
Correct. You do need to make sure that, yes, any patient, regardless of the location, needs to meet that criteria. And again, if you reference, or if there's any questions, you can reference the website. The EUA is there, as well as we do have a example order template that can be utilized that essentially outlines a eligibility checklist for you, along with the physician orders for the drug and flushes and such, that if you follow that criteria, again, to assess high risk patients. So I'm not going to go through all the criteria on the call because it's there in the black and white. We've talked about it, but it is there for reference. And again, if you adapt or utilize the order template and you're following that process and that checklist there, you will be successful in determining those patients that can get the drug, whether it be in a long-term care facility, a prison, as we've expanded the program. But yes, correct, Jen. That's very important.
Yep. And again, those resources, we do have a couple questions here too about those qualifications, and those resources are on the pilot program website. And if you have further questions about that, please feel free to reach out to the team. All right. You know, Ryan, last week we talked a little bit about some new information about vaccines and whether they can still get BAM and after they've been vaccinated, and then how long after they've gotten BAM would the vaccination be able to be given. So if you could kind of run through that again. There's some questions about the intersection between vaccination and BAM.
Yeah, so I did send out an email, so I can certainly send that out again. It may have, you know, gotten lost in the email mountain, as we call them. But essentially the CDC guidance is if a patient gets a dose of Bamlanivimab and then has the opportunity to get the vaccine, there's a 90-day period. So therefore, let's say the patient got the dose of Bamlanivimab today, they would have to wait February, March, April till April to potentially get the vaccine. Again, it's a 90-day period, and essentially that's just because they feel that with the response and how the vaccine and the monoclonal antibodies work, that there could be some, you know, physiological competitiveness with your immune system over, you know, what's going to take the priority. And so they don't want either to be lessened or weakened as a result. In the CDC guidance, it is slightly confusing. A little bit, because they do also then mention about a patient that would have gotten a dose of the vaccine, but then still tests positive for COVID after that, because as we know, currently the two vaccines are double dose and immunity isn't fully reached until after second dose, you know, mid to high 90%. So there is that chance where a patient could get the first dose of the vaccine and then, you know, potentially still test positive. Again, the guidance there is a little bit gray, but erring on the side of caution, it wouldn't necessarily preclude someone from getting Bamlanivimab after they got that dose, but I would encourage you to recommend to look at the CDC guidance and work with a physician that you would be working with in determining what would be the best course of the patient, because I think those situations will be very patient specific given the patient's status clinically and some other things going on with them. But if they do get Bamlanivimab, it is very straightforward that they should wait 90 days to get the vaccine.
Great. Thanks, Ryan. And again, I think it's worth sending out again. It is a little bit confusing, and we want to make sure that everybody understands the protocols. And I think we have heard that message maybe not be getting out to the skilled nursing facilities, and we want to make sure that everybody has the correct information. So moving on here, I think this one actually will be for Bill. On the AB, has anybody been seeing AB Max paying on a locality rate, which might see a rate different than the 309?
I haven't talked to anybody regarding the actual rates they've been paid, but I understand that there is a geographic wage adjuster that is applied to that rate. It is likely budget neutral, so some would be lower and others higher that would equal out to that 309, similar to the new home infusion services benefit. So yeah, I think it is possible that there is a different rate based on the geographic location. I did read that this would be adjusted for geography.
Great, thank you. And then again, I think back to you, Bill. Does the nursing agency or skilled nursing facility need to be enrolled as a mass immunizer, or only the person billing?
Excuse me. The best way for a home infusion pharmacy to enroll is to either, or to be enrolled is either to be enrolled as an AB Mac pharmacy or a mass immunizer. Other entity enrollments, I didn't really consider when I made that statement. The link that I provided to enrollment has a long list of entities that can bill for COVID vaccines. So the skilled nursing facility and home health agency do not need to be enrolled as mass immunizers. An HIT supplier, the new HIT supplier type that just went into effect 2021, does need to be enrolled as a mass immunizer in order to bill, which I was a little bit surprised about. That's in the new FAQs that I mentioned and was the last link on the page of a number of different resources. So the home health agency does not. They can submit claims. They don't need to do any new enrollment, and the skilled nursing facility can also submit. They don't need to do any enrollment.
Okay, thanks, Bill. And then I'm not sure we know the answer to this, but I know Connie's on the line, so she may have heard more of this. Some of our providers have a PACE program, which is an inclusive care for people 55 and older who require nursing home level care but can remain in the home. They go to PACE clinics to see physicians and receive medical treatment. Is there any talk, or can this be included in our pilot? Connie, I don't know if you've heard anything about that. Looks like Connie might be having some technical difficulties. Ryan or Bill, have you heard anything about the PACE program and inclusiveness there?
I have not at this point. I mean, I'm familiar with the PACE programs that folks participate in. I think it's something we probably could double check and ask and get back to folks on.
Yeah, so we'll follow up and get back to you on that. The other piece is, we have talked about this in prior calls, but if you get a request to administer BAM outside the pilot criteria, so not in a skilled nursing facility, long-term care facility, you can email Ryan or myself, and we have a process that you can follow to try to get an allocation from another area. So if the PACE program's not covered, we will follow up with you on that, but we will also send you in the meantime that information on how to get an allocation for drug outside of our pilot allocation. So I think that's our last question actually for today. So we will please feel free to reach out to any of us if you have any further questions. Before we sign off, I did want to just congratulate our new class of fellows that was announced today. NHIA has sent out an email congratulating those fellows, and I would like to definitely say thank you to that group because they have had such an instrumental impact on home infusion and NHIA. So thank you so much and have a great day. Bye-bye.